program in leadership and governance, supported generously by the Christian Endeavor Foundation, is designed to bring to Princeton leading practitioners and leaders to interact with our students and let them know about the opportunities of public service. So we're very delighted that Dr. Orzag has been willing to come and spend time with students and faculty over the last 2 days. And we especially would like to thank Margaret Cannella, class of 72, and her children, Catherine and Michael Riley, for their support of Dr. Orzag's visit. Peter Orzag served as the director of the Office of Management and Budget under President Barack Obama and helped to shape the 2009 stimulus package and healthcare legislation that passed in 2010. He was also the director of the Congressional Budget Office in 2007 and 2008, where he sought to draw attention to the long-term fiscal consequences of rising healthcare costs, the topic of this afternoon's lecture. He is now a contributing columnist for the New York Times and will be writing at the NewYorkTimes.com Opinionator. Before joining the Congressional Budget Office, Orzag was a Joseph A. Peckman Senior Fellow and Deputy Director of Economic Studies at the Brookings Institution. While at Brookings, he also served as director of the Hamilton Project, which provides a platform for scholars to offer proposals for promoting broad-based economic growth. Director of the Retirement Security Project, which focuses on promoting retirement security, and co-director of the Tax Policy Center, a joint venture with the Urban Institute, providing analysis of tax issues. In previous government service, Orzag served as Special Assistant to the President for Economic Policy and Senior Economic Advisor at the National Economic Council. He has been the Senior Advisor and Senior Economist at the President's Council of Economic Advisors, where he was first appointed as a staff economist in 1993. Welcome to Princeton. Well, welcome back to Princeton.
Thank you. I'm delighted to be here. I've particularly enjoyed spending the last 2 days sitting in the classes and visiting with students. It's frankly inspiring and delightful to come back to a place where you can see the future. I should also say that before I get to the heart of my talk, an appropriate degree of modesty is in order, since things don't always turn out as I predict. An example occurred my very first weekend in office after being quickly confirmed by the United States Senate and hiring a crack team at OMB in record time. I almost set the White House on fire for the first time since 1812. It was a very cold weekend, and I was unfortunately spending it in my large office, which was particularly cold given how large it was. And I still can't figure out whether this was a trick played on me or not, but there were not only logs placed next to the fireplace, but a fire screen and tools, fire tools. I inquired as to whether the fireplace was operational and was told that it was, but being somewhat skeptical, I wanted to make sure the flue was open, so we lit a little piece of paper to see whether it was venting, and it was, and then lit a large fire with the logs and the fire tools that were right next to the fireplace. That was working very well, and the room became quite warm and cozy, and I was very pleased with my new job at that point. Unbeknownst to us, 3 or 4 years earlier, the Secret Service had capped the chimney. So while the smoke was not filling up in my office, and in fact the fire was quite lovely, it was, of course, going up the chimney and coming out in a 5th floor conference room. Fire alarm goes off. The Secret Service is evacuating the building. I'm trying to explain, I think this might have something to do with the fire alarm. And the Secret Service assured me that no, it was an electrical fire started on the 5th floor. 20 minutes later, they came to a different conclusion. And my mother was quite pleased that my picture was being shown on CNN until I explained why. So I think, I hope you keep that in mind as we go through this discussion, since, again, I didn't light the fire again, so I do learn my lessons, but things did not quite turn out as I had initially anticipated. I don't think I'm going to say anything today that is novel or that I haven't said before, but I hope to bring things together in a way that I haven't had the opportunity to do previously. And let's first talk about the underlying problems that we face, and then I will turn to what the most recent piece of legislation does or does not do to address some of them. The first is that our long-term fiscal future in the United States is disproportionately driven by healthcare costs, and I hope that this graph makes that case compellingly. The light blue part of the curve is Medicare and Medicaid costs. The dark blue is Social Security, and the thing below that is all the rest of federal spending. And it is not hard to see from that graph what is driving the uptick in spending over time. It's Medicare and Medicaid. Another way of putting the point is Social Security spending is projected to rise by a little bit more than 1% of GDP as the population ages. Medicare and Medicaid by many multiples of that. Now, there are differences of opinion in how one should project the rate of growth in healthcare costs in the future relative to the past. But I think that just proves the point, which is that if this were to grow, if the rate of healthcare costs were to grow a 0.5 percentage point per year, more slowly or more rapidly, that drives a much larger change in the fiscal outcomes in 2040 or 2050 than, frankly, what happens to the rest of the budget. So one can quibble with the central projection, but what I think is unambiguous is there's a lot of uncertainty surrounding the rate at which healthcare costs will grow in the future, and that is the single most important determinant of our long-term fiscal outcomes. Second observation, this is not a problem or an issue that is solely a Medicare and Medicaid issue. And in fact, over long periods of time, the rate of growth in Medicare and Medicaid has tended to track the rate of growth in the rest of the healthcare system. This is the so-called excess cost growth rate, which is the rate of growth in spending per person or per beneficiary relative to the rate of increase in income per capita. And I think you can see, over a 30-year period, very similar rates of increase in Medicare, Medicaid, and the rest of the healthcare system. This is not surprising because hospitals treat both Medicare and Medicaid patients, non-Medicare patients, and it would be surprising if the things that were affecting healthcare delivery for a certain subset of patients were not more broadly applicable to the healthcare system as a whole. Third observation is, and I'm going to come at this from a bunch of different perspectives, but both international and intra-US regional comparisons suggest that we have more costs in the system than an appropriate benchmark would suggest. This is, I think, perhaps the best international work that has been done, which is from the McKinsey Global Institute. And what it does is it tries to break down a difference between the United States and other countries in healthcare expenditures and where the differences are arising. So in particular, out of almost $500 billion above benchmark spending level in the United States, you can see that a component of that is located in hospital care, the $224 billion. But the key thing that I wanted to raise here is it's sort of spread throughout the healthcare system. Often there's a desire to say the solution here is to clamp down on pharmaceutical pricing, even though that's only 10% of total healthcare spending, and so it would be surprising if that could be the solution. Or all we need to do is pay doctors differently or less or more or whatever. Again, surprising given that would be surprising given the share that is directly attributable to doctor salaries. Or let's cut back on administrative costs and insurance profits. All of this would help, but the point that I want to make with this chart is the excess costs are spread throughout the healthcare system, and there's not one individual area that is going to be the solution to either the level or the rate of increase in healthcare costs. So that all sounds kind of challenging, but I actually do think that and what I'm about to say is controversial also, although perhaps a little less so than several years ago, I think there's a significant opportunity to wring those costs out of the system in a way that does little harm to healthcare quality. And the reason I say that is not only the cross-country comparisons, which are often difficult to do well given the differences across national boundaries, but the huge variation that we see in the United States in cost per beneficiary in Medicare, in Medicaid, and frankly in private insurance settings also. This map shows the level of spending per Medicare beneficiary across different parts of the United States. You shouldn't read into the fact that the more expensive regions are red as opposed to blue. Just take them as different coloration. And what you see, the big thing that I want you to take away from that chart is there is a lot of variation in the cost per beneficiary across different parts of the United States, with some parts of the United States costing 2 or 3 times as much as other parts. If you go to most major employers in the United States and ask for a similar graph, the specific areas are not always the same, but the basic point of dramatic variation in private health insurance costs also comes across very clearly in their own internal data. Now, there's been a lot of effort put into trying to explain why these costs vary, with a group at a different university, which will remain unnamed, spending a lot of its time trying to explain the variation. And I think the best reading of the evidence is that you can narrow the variation by maybe 1/3 to 1/2 when you throw in explanatory variables like the health of the population in different areas, the cost of the prices of building hospitals or paying doctors in different areas, et cetera, et cetera. But you can't eliminate it. There's a substantial amount of variation that persists after you throw in every explanatory variable you can. The second piece of this observation, and this is where the data get murkier, is that at least to a first approximation, and I should say again, this is there is an ongoing debate about this point, but I think that the weight of evidence from my perspective suggests that the higher spending regions and the higher spending hospitals within a region do not generate better outcomes than the lower spending regions. This is a very simple and crude measure where you're taking at a state level spending per beneficiary and looking at a composite measure of quality, which is admittedly imperfect. And if anything, the correlation goes the wrong way, with higher spending areas having a lower measure of quality than the opposite. Certainly the absence of a strong positive relationship. I'm going to skip over this. The question then becomes, what is driving this variation, and does it offer some hope for obtaining a better combination of cost and quality within the United States? And before we get to potential responses, one thing to note is that the variation seems to be occurring most dramatically where it's less clear what should happen. So for example, administering an aspirin to someone who suffers a heart attack when they're admitted to a hospital. That is very clearly best practices, and it's clear there's little ambiguity about the intervention, little variation in what happens there. This chart, in case it's unclear, is if you're on the vertical line there, the 1.00, there's basically no variation. That map would look all the same color. The further away you are from that vertical line, the more the colors would come out in the map. And what you see is, as you go down to the more ambiguous cases, so how often should you go back and see a doctor after you've been discharged from the hospital? Once a month, twice a month? No one really has great clinical evidence on the benefit of the nth visit relative to the n-1 visit. There's a lot more variation in those kinds of, that was the evaluation and management visits, a lot more variation. The use of high-tech imaging and diagnostic tests, where, again, the benefits are often somewhat ambiguous, a lot more variation. The takeaway here is where there's more evidence on what works and what doesn't, the variation tends to be more narrow than where there's more ambiguity about what should happen. And that's a theme I'm going to come back to later on. Now, one response to all of this is that's great on average, but clearly we have the world's best medical centers in the world, so they must have clarity and consistency in how they are practicing medicine. And I think even there are huge questions that Professor Reinhardt and others have raised about the variation that we see across leading medical centers. As one example, if you compare UCLA Medical to the Mayo Clinic, the cost per beneficiary in that total Medicare spending line, this is for the last 6 months of life, is about $50,000 a year at UCLA Medical and about $25,000 a year at the Mayo Clinic. It led Professor Reinhardt to ask how the best medical care in the world can cost twice as much as the best medical care in the world. And I think that's actually an important question, because what seems to be happening, and of course I'm never going to actually be admitted to be a patient at UCLA Medical anymore, but what seems to be happening is that there's much more days in hospital, much more use of specialist services, much more testing. And the counter response is that's all necessary given the population that we see and the nature of the patients. But I don't think the evidence is clear that that's the full explanation for this variation. In order to get true evidence, we have to randomly assign people to go to the Mayo Clinic versus UCLA Medical, and no one seems to be willing to conduct that experiment for reasons that I don't fully understand. So we're stuck with this kind of imperfect analysis of trying to explain as much as possible patient differences and then seeing whether there still is a significant variation. And my going in presumption is that there still is a significant variation in how healthcare is practiced at these different institutions. We'll again come back to that. Okay, so now let's turn from the underlying problem to what was just enacted and whether it does anything to address any of these problems, because I'll get to trying to explain the conventional wisdom later, but the conventional wisdom is that the bill does nothing to address any of those problems, and while it does a good job at expanding coverage, it does nothing on cost containment or quality. So let's examine the facts on that and then perhaps also try to explain the conventional wisdom. And the bottom line for those who want to take a quick nap in the middle of the talk is that I think the bill does more than the conventional wisdom suggests, which is not challenging since the conventional wisdom is approximately 0. That more will be necessary, but that there are building blocks in the bill that are, with one exception, which I'll return to, as promising as any alternative. And typically, when I am faced with people who say the bill doesn't do enough on cost containment, I ask, okay, what specifically else would you do? And the answers are often either in the bill already, or we'll get to the other responses. But I think that's the frame that I'd like you to have in your mind, which is, if this doesn't do enough, what else specifically should be done to address this problem? Because if there is nothing else, then it's all hopeless, and we might as well just throw a big party because we're back on that ever-rising cost trend anyway, and our fiscal trajectory is fundamentally unsustainable, and there's no point even trying. That is not the conclusion that I hope you will reach, but we will see. First, let's just look at the raw facts, because that's a decent place to start. If you fully implemented the bill, and I'm going to come back to what it means to fully implement the bill, you would be on this line that's labeled current law in this graph. A very dramatic change from the first graph that I put up. The right question to ask is, well, okay, are we going to fully implement all the provisions in the law, and is this remotely plausible? I'm going to come back to that in a moment. The illustrative alternative is something that the actuaries at Medicare have put forward, in which you assume that only 60% of the bill is actually implemented over the long term. And if I therefore showed what would happen with none of the bill implemented at all, you'd have an even more sharply like the original graph that I showed you. Bottom line from this is, if what's written on paper is fully implemented, there's a significant effect. Now, we're going to come back to whether it will be fully implemented in a moment, but that's at least a factual statement that has not really been out in the public domain with regard to the impact of the bill. So why is it, before I get to whether it will be fully implemented, why is it that the popular impression is so different than this graph? I think if you showed most people this graph, they would not relate that at all to the health bill that was just passed, because it seems so dramatically different than the descriptions that are out there. And I have two main explanations for that. The first is that first impressions matter a lot. And during the summer of 2009, when first impressions about the health bill were formed, the only bill that was out in the public domain was the bill from the House of Representatives. In healthcare reform, there's always tension between cost and coverage. And folks lean one way or the other. The House bill leaned way towards coverage and was legitimately seen as not doing enough on underlying cost containment. That then became the prism through which health reform was viewed. And even though the final bill does a lot more, in fact, the two most important provisions in the final bill, I'll come back to them, the excise tax and the Medicare Commission, weren't even in the House bill at all. And the final bill being much better than the original bill, it didn't matter because that was the perspective that was formed, and it's hard to overcome first impressions. The second major explanation for popular wisdom is that real cost containment is messy. It's not easy to, there's not a snappy little, here's what we're going to do. It instead involves a variety of measures to try to get at especially provider incentives, and it's not easy. So in addition to first impressions being formed in the wrong way, there's not a simple bumper sticker version of true cost containment that is factually accurate or that is reflective of the bill. And let me try to explain what I mean by that latter point, because it really gets to the heart of the problem that we face. There are four basic approaches to cost containment over time. You can reduce prices, that is the payments that are made to doctors and hospitals and insurance companies and to providers writ large. The bill, I'm going to talk about this in a moment, bill actually does a fair amount of that, but ultimately that is not a real answer, because if all you're doing is ratcheting down reimbursement rates without getting at the underlying intensity of services provided, you're ultimately going to run into a problem. And especially if you're not affecting the underlying intensity of services provided in the rest of the health system, given the initial observation that I pointed out about healthcare costs tending to track each other over time, what you would be doing is creating an access problem. As you ratcheted down payment rates for Medicare beneficiaries without affecting the rest of the health system, you're just going to create problems in finding a doctor or hospital willing to treat Medicare beneficiaries. So there's a lot done. I'm going to go through that, but not as much as you, it's ultimately not a sustainable answer without getting at the intensity of services provided. The second approach is rationing, which does get at the quantity of services provided, but I don't think is very likely to be politically viable in the United States, even if it were desirable, which is debatable. The third is consumer-directed healthcare, and then the final one, which is where I think the bulk of the effort has to go, is in provider information and incentives. So let me try to walk you through each of these things in turn. First, with regard to the just raw provider payment and reimbursement rate reductions, the bill includes a whole bunch of that, hundreds of billions of dollars in it in particular. So the blue bar is a reductions in payments to hospitals and other providers under Medicare. It's not an outright reduction, it's a slower growth rate relative to the rate of increase that would otherwise apply, basically knocking down the update factor that would apply each year to a slower growth rate than is scheduled under current law, almost $200 billion. More than $100 billion in reducing payments to Medicare Advantage plans, which cover roughly a quarter of Medicare beneficiaries. These are private plans that all of the evidence from CBO and elsewhere suggested were being overpaid relative to the cost of providing insurance through traditional Medicare. So to a first approximation, what this is doing is knocking the payment rates for Medicare Advantage plans back down to close to parity, with a few regional variations that we can talk about, parity with providing coverage under traditional Medicare. And then there are some reductions for disproportionate share hospital payments in part reflecting the fact that those payments were supposed to reflect treating the uninsured and not being compensated for that, and the number of uninsured people will go down dramatically as a result of the legislation. But the takeaway here is there's actually a lot of provider payment reductions contained in the bill, so that first category is sort of covered in terms of significant cost containment. What about, I'm going to leave rationing aside because, again, it's not particularly plausible. So let's talk about the most popular approach to reducing the intensity of services provided through so-called consumer-directed healthcare. And what that entails is the correct observation that when you don't pay for something, you tend to consume more of it. So if you have higher cost sharing, you will consume less of it. And that is analytically correct, but and more widespread cost sharing would help to reduce healthcare costs. But there's a fundamental limit to how much it would help. So consumer-directed healthcare is now being held up as a panacea, whereas it would help a little, but not as much as you'd think. And the reason for that is even under consumer-directed healthcare, we are always going to provide generous insurance against high-cost cases. After all, that's the whole purpose of insurance, to provide generous protection against high-cost scenarios. And in healthcare, unlike many other markets, the high-cost cases account for the vast majority of total cost. So this chart shows you on the left the share of beneficiaries ranked by cost in Medicare, and on the right their share of costs. The top 5% of Medicare beneficiaries account for 43% of costs. The top 25% of beneficiaries account for 85% of costs. Consumer-directed healthcare will, to a first approximation, be most applicable to the other 75% of beneficiaries who account for 15% of costs. So yes, you will help to reduce healthcare expenditures, but the traction that you get is much less than you'd think because you're not really affecting, to a first approximation, those high-cost cases. Now, I should immediately say there might be some effect. The RAND experiment from the 1970s, which unfortunately now is quite old, did suggest that cost sharing below a catastrophic limit had some effect on spending above the catastrophic limit, in part because perhaps, for example, people don't even enter the hospital in the first place. But the effect was pretty modest. So something, but not a lot. CBO has suggested, the Congressional Budget Office has suggested, a universal system of consumer-directed health plans would reduce health expenditures by somewhere between 0 and 5%, and probably a little bit closer to the lower end of that range. So something, but not end-all be-all. To a first approximation, therefore, we're getting to the core of the issue, which is in order to contain healthcare costs, you have to get at those top 25% of cases, the high-cost beneficiaries who drive the overall majority of overall costs. And what I'm going to propose is that to a first approximation, the healthcare delivered in those cases is what the provider recommends. And therefore, you have to get at what the provider is recommending in those high-cost cases, which often involve chronic conditions like hypertension and congestive heart failure and diabetes. And it's messy to get at the healthcare that's recommended in those cases. I should also immediately say these cases are what drive the vast majority of that variation that we saw across the United States in the first place. That was, the variation was often, for example, for the medical centers, it was for the last 6 months of life. Those are disproportionately the high-cost cases. So to observe that we have to get at the high-cost cases and that there's a lot of variation in the United States in healthcare costs are actually mirror images of the same phenomenon. Let me talk about a few of the things that are being done to try to get at those provider incentives and information, because I think that there are two basic ways of getting at what the providers are recommending in those cases. The first has to do with an information flow. I already mentioned earlier that the variation is smaller when there's more information about what works and what doesn't. And the second is financial incentives. So let me talk about those in turn. In order to move to the healthcare system of the future, and I'm going to go off these slides a little bit because they're not exactly the way I thought they were. sometimes happens, it's my fault. In order to get that positive flow of information, the healthcare system of the future requires much more health information technology, backbone, a system for evaluating information being produced by that HIT backbone in terms of evaluating what's working, what's not, and then a way of feeding that back to doctors and hospitals through clinical decision support software and other tools in order to get it into widespread clinical practice more rapidly. So let's talk about each of those components. The stimulus bill actually, in a way that I think many people didn't appreciate, included a significant amount of health information technology, subsidies, and then penalties for not adopting health information technology. Almost $20 billion provided in subsidies, and then after 2014 or thereabouts, penalties for not adopting health IT systems. The government just clarified what it means to use health IT systems through the so-called meaningful use rules. And I think over the next 10 to 15 years, you're going to see a significant change in the share of hospitals and doctors who are using health IT systems, both because the technology is getting easier with iPads and more mobile computing devices being less disruptive to the workflow, and because there are these subsidies and then penalties built into the Recovery Act in particular. So that's the first piece. The second piece is then research into what works and what doesn't. The Recovery Act, the stimulus bill, started a significant expansion in this so-called comparative effectiveness research by providing more than $1 billion to conduct it. And importantly, the health bill then dramatically expanded it by creating a new patient-centered outcomes research institute and giving it mandatory authority, mandatory spending authority to conduct this kind of research. The final piece then has to be feedback to practical clinical settings. And part of that can occur through clinical decision support software. I think I would love for my doctor, when I go in to see him, to be able to, in talking through my condition, to be able to pull up not only a clinical guideline that has been issued with regard to it, but to be able to then click through to the individual studies that are the basis for that recommendation and see whether my individual characteristics cause him to recommend a different course, but to have that prompt and then the ability to adjust to individual characteristics. And let me just jump ahead and say, I think one of the shortcomings of the health bill is I wish that an additional factor that would reinforce that feedback loop would be a change in medical malpractice laws that would reinforce that positive loop. And in particular, let me just turn to that for a moment, even though now I'm completely off the slides. I hope you're all okay with that. We're going wild here at Princeton University. In particular, the medical malpractice system is currently based on a customary practice norm. So your defense against liability is that you were doing what doctors tend to do. That is one of the sources of the variation that we see in how healthcare is practiced across the United States, because that reliance, I'm doing what the guy down the hallway is doing, causes contagion or social norms among doctors and hospitals. So if for whatever reason a more intense approach gets adopted in a particular area, it tends to spread in that area because you're then doing what everyone else in that local setting tends to do. It's also, by the way, that, let me just pause on medical malpractice, because there's this interesting disjuncture between doctors and hospitals and academics. So I'm going to simplify, and there are caveats that I'll give in a second, but basically every doctor and hospital says this is tort and medical malpractice by far the most important explanation of healthcare costs, and pretty much every academic says it has nothing to do with healthcare costs and has almost no impact. And it has almost no impact also on the variation that we see across the United States and how healthcare is practiced. I think that I am actually a little bit closer, and I hesitate to say this in an academic institution, but I'm a little bit closer to the doctor-hospital perspective here than the academic literature perspective here. And the reason is to focus just on the practice variation perspective for a second. The studies that examine whether the variation that I showed is driven by malpractice tends to examine, let's look back at that map with the different colors, and do you see a more stringent set of caps under malpractice, limits on liability, in the lower cost areas relative to high cost areas? And it turns out that that correlation, it doesn't really exist, and therefore the conclusion is this is not driving the variation. But what that misses is this customary practice norm. If the emphasis on customary practice is causing a strong social norm to develop among doctors in one place and in another place, and that social norm is not that affected by whether the cap is at $500,000 or $750,000, then by examining how the cap varies, you're missing the fact that the customary practice standard itself is one of the factors driving this variation. And so what I would favor is a change in the malpractice system towards a safe harbor for following clinical-based guidelines issued by quality improvement organizations or the American Medical Association or the Institute of Medicine. And I admit that there are flaws in that approach, which we could discuss, but I think it's a lot better than the one that we have now. It would help narrow the practice norms variation that we see. It would help spread evidence-based medicine more quickly than we currently have. It would give Democrats a form of tort reform that they should support, and it would provide more clarity to doctors, especially with the, imagine a world in which that suggestion for you as a patient comes up and the doctor has 2 or 3 different guidelines issued by different organizations if necessary, not federal government ones, and clarity that if he or she follows them, especially if they're consistent, which would be nice, that there's a safe harbor under the malpractice laws. I really do believe that that would help to spread evidence-based medicine rapidly and is as important as the direct financial incentives that we'll discuss in a moment. By the way, I should also say, we'll come to the election in a moment, but well, let me do that. The second part is how do you get at the financial incentives facing providers? Because currently we have all of these incentives for more intensity rather than better care. And I think there are lots of very promising ideas out there. So accountable care organizations where doctors and hospitals would be grouped together and jointly try to manage the health care that is provided to beneficiaries. Pay for performance, in which you would pay more for higher value and higher quality care. Bundled payments, in which you would provide a flat rate for treating a beneficiary with diabetes, for example, rather than paying for each individual intervention. Penalties against hospital readmissions and hospital-acquired infections. So these are all promising ideas, and by the way, they're all in the bill. The problem really is that we need to move beyond that, because while everyone agrees that what we need to do is move from here to there, move away from paying for intensity and towards paying for quality, no one really knows exactly the path that will take us there, and the healthcare system is dynamic anyway. So all of these are great. By the way, they've never been done on a national basis in any significant way. So even if you were the benevolent dictator, I think it would be a mistake to just go national immediately on any of them. Instead, what we need to do is try them and have an approach where we're much more facile about, much more quick to move to scale on the promising ideas. And one of the frustrations is, this is in part why this doesn't fit on a bumper sticker, because getting from here to there is going to involve a zigzag path where we take several steps forward and a couple back and several steps forward, and we need to have a much more adept process of doing that. So perhaps the most important changes in the health bill along this dimension are the things that allow policymakers, through Medicare in particular, to do that more rapidly. And there are 2 in particular that I would identify. One is the Innovation Center in Medicare and Medicaid that allows the secretary to try out different things like accountable care organizations or bundled payments. And then the important thing is move to scale on them if they're promising without the need for additional legislation. That's one kind of process change that I think is particularly important. But perhaps the most important thing, and the thing that was the hardest to actually get included in the legislation, is the so-called Medicare Commission, or technically the Independent Payment Advisory Board. And let me try to explain what this is, because it may turn out to be the most important component of the health legislation from this perspective. The Independent Payment Advisory Board is given the legislative task, and it's, by the way, one of the reasons that if you fully followed current law, that curve looked so good that I showed from the bill, in ratcheting down the rate of increase of healthcare costs in Medicare, and actually a little bit in overall healthcare costs, but in Medicare in particular, over time. And the important point to note is that after it starts this process, its recommendations take effect by default. So it puts forward a set of recommendations to hit a target growth rate for the rise in Medicare costs. And if the Congress ignores them, they take effect. If one house of Congress votes them down, they take effect. If both houses of Congress vote them down and the president vetoes that bill, they take effect. In an environment of increased polarization in Washington, D.C., in which I can attest by personal experience, it is becoming increasingly difficult to do anything, inertia dominates. And in a very polarized world, what happens by default to a first approximation is what happens. This entity has changed the default, or will change the default. So what it puts forward is what happens by default. And let me give you an example from the past 2 weeks. A couple weeks ago, David Leonhardt, writing in the New York Times, talked about a new proposal that has been put forward by Peter Bach and a colleague on changing the way we reimburse for new technology under Medicare. In particular, what he would propose, and he used the example of prostate cancer. So in prostate cancer, there are 3 different treatments that are possible. There's an older one that costs $10,000. There's a newer one that costs $40,000. There's a brand new one that costs $50,000. The available evidence suggests the $40,000 and $50,000 treatment's no better than the older one. What he proposes, we reimburse in full for new technologies for 3 years. And if after 3 years they haven't been shown to be more effective than the older technologies, we reimburse at the rate of the older technology. So in that situation in particular, we'd reimburse at $10,000. I would suggest to you that the probability that a proposal like that gets enacted into law by the United States Congress in a polarized environment, pick your fanciful observation, is about the probability. This morning I said it's about the probability that I get to hit a home run out of Fenway Park, but it's very close to 0. I checked with the authors of that proposal to make sure that the Payment Advisory Board could put forward a proposal like that, just as one of hundreds of examples that that one should think of. And the answer is that it could. So the probability that that actually becomes policy through this default process might not be 100%, and I would never claim it is, but a lot higher than the probability of getting it directly enacted as a new piece of legislation. And that's one of hundreds of possible examples of things that could be tested out, and if they work, take effect by default. I'd also point out that if you're going to have any hope of actually evaluating efficacy within 3 years to any rigorous, in any rigorous way, that health IT system and the comparative effectiveness research is going to be crucial, because we need a lot more clinical information about what's working and what's not to be able to make a decision within a 3-year window instead of 15 or 20. And even then, an appropriate degree of caution will be warranted. But that is the kind of idea that could be done through the Medicare Commission that would be extremely challenging to be done in the absence of the Medicare Commission, and one of many reasons why I'm somewhat more hopeful that this structure can work. Now, it's got a lot of potential power and potential impact, but in reality, it will depend on who the leadership is and the culture that develops and what have you. The example I like to give along this dimension is, it was mentioned earlier that I ran the Congressional Budget Office, which, by the way, my children refer to as the Congressional Boring Office, and they were quite displeased when I left, since they didn't have that little line anymore. But if you look at the Congressional Budget Office, On paper, the Congressional Budget Office would say the Congressional Budget Office would have no impact. In particular, its budget is set each year by the Congress. Its director is appointed by the Congress. Its director can be dismissed by a simple majority vote in either house of the Congress. You look at that institutionally and say that thing is going to do nothing. In reality, it's done a lot because, and I credit this to Alice Rivlin, the first director of CBO, established a culture there that was independent and analytical and rigorous, and it developed into an entity that when I served as director, it was almost judge-like in the sense that I was actually quite surprised by how little political pressure was applied to me. I think in part because most senators or representatives thought it would backfire, which by the way is probably right. And even though on paper it didn't look that powerful, in practice it plays a very important role. So similarly here, there's a lot of potential on paper, but whether it actually realizes that potential will depend on whether there's another Alice Rivlin type figure who can help it to realize its potential. Another major part of, since I mentioned earlier that you don't just, that overall healthcare costs tend to grow at relatively similar rates over long periods of time, one theory of the case here is that Medicare, by changing the payment system, will help to contain overall healthcare costs. But the bill includes another important lever to try to reduce private health expenditure growth, and that is the so-called excise tax, which is also referred to sometimes as the Cadillac tax, which will impose a tax against high-cost plans starting in 2018. That will provide a very strong incentive. Now, interestingly, typically as it happens in policy world, the legal incidence, the tax is imposed on insurance companies, but most of the revenue is not going to come from collecting that tax from insurance companies because firms will redesign their plans to avoid the tax being applied. And so most of the revenue that is assigned or that was projected for this tax comes from companies redesigning their plans, paying more in wages and less in tax-preferred health benefits, and the additional wages then being taxed relative to tax-preferred health compensation. So let me take this as an example because people have often said, I want to come back to, will the bill actually do what it says? And the Payment Advisory Board is an example where there's some risk that it won't if the culture doesn't, bless you, if the culture doesn't develop appropriately. But the excise tax is one that has been bandied about as, oh, come on, this thing doesn't take effect till 2018. Are you kidding me? Will never happen. And let me explain why I think, while it may get ultimately repealed, I think that's a much less likely scenario than conventional wisdom. Again, I'm making it easy by presenting conventional wisdom as saying it's a sure thing that it will get repealed, which I think is approximately conventional wisdom. Let's evaluate what the world would be like in 2017. So if you were going to repeal this tax in 2017, given that we're going to be in a more severe fiscal environment than currently, and given that there's a statutory pay-as-you-go law, you would need a 60-vote majority of the Senate to replace, you either need to offset the revenue that you lose, which would be 10 years of revenue at that point, or you need to waive the rules, both of which are quite awkward. So this is not a trivial walk in the park kind of vote to repeal. Second, if I'm a CEO in 2014 and I'm looking forward and saying, well, that may or may not happen, it's polarized, I don't know that I can get 60 votes in favor of anything, by default the thing takes effect, I'm nervous about that, I would do what many CEOs are actually starting to do now, which is redesign my plan to take that risk out of the equation. And many companies are now starting to do that already. To the extent that that happens, interestingly, you attenuate the political need to remove the tax, because if you're already on a glide path to avoiding it, the political pressure to repeal is dramatically reduced. And ironically then, you would start collecting revenue in 2014 or 2015 as health plans were redesigned and after-tax wages rose in response to the redesign. All of which is to say, and layered on top of that, the history of delayed implementation in the United States is not nearly as pessimistic as the people who say, oh, it will definitely be repealed suggests. An example is the delayed implementation of the increase in the full benefit age or normal retirement age under Social Security. It's taken effect. Most of the delayed implementation provisions that have been built into the law in the past, in part because of the power of inertia and defaults, have actually taken effect to a much larger degree than you would initially think. You put that all together, it may not be 100% percent probability that it is implemented, but I would put a much higher probability on it taking effect in 2018 than the conventional wisdom suggests. So let me talk about, in just wrapping up, some of the critiques of the bill and then what might happen at this point. Because again, I want to be careful. This is not an A. This is sort of a B, and you know, it'd be great to have an A, but it's also a real piece of legislation. So, what are some of the critiques? I already mentioned I had jumped ahead to medical malpractice, and I actually do think that that would have been a beneficial part to the health reform bill. There's some very small pilot projects that are included, but nothing major. Okay, so what are the other critiques? The fiscal hawk types, the world from whence I come, say, that's all great. It's good that you got a couple $100 billion in deficit reduction through Medicare and reduced Medicare Advantage payments. But, and yeah, I like the excise tax and the Medicare Commission. That's all great, but you shouldn't have expanded coverage. And by expanding coverage, you created a fiscal risk in the future. I guess the response is, let's actually break that down a bit. And I'm going to now be very cold-hearted and assign no weight to the both moral and other benefits of expanded coverage. So I'm just going to adopt the narrow fiscal frame as if expanded coverage had no social benefits associated with it. So I hope everyone understands that that's what I'm doing, and I don't mean to say that expanded coverage is useless. Let's look at the claim. First, there were several $100 billion of provider payment reductions that were incorporated into the bill, and also an excise tax that would never have happened in the absence of coverage politically. You never, just pure deficit reduction, you might have been able to get $200 or $300 billion of provider payment reductions, no excise tax, because it was a battle even with the coverage. So let's say that that's 0.1 or 0.2% of GDP in foregone deficit reduction measures that you're giving up. In exchange for that, you're getting a bunch of things that actually could help to contain costs, more deficit reduction provisions than would otherwise be the case, and especially both the excise tax and these process changes, the Medicare Commission in particular, that offer more hope than just the traditional approach of ratcheting down provider payments. Another way of putting it is, the only thing that would have been feasible with a straight up deficit reduction package is a set of narrowly confined and smaller in size traditional payment reductions that are nice, but that don't get at the heart of the underlying long-term problem because they don't start the arduous process of changing the financial incentives and delivery system in the health system. Second critique is should not have done it now, and I will leave that for others to debate, other than to say it's never convenient to do it ever. But I will leave that to the political scientists to debate rather than engage on that. Final, another critique has been that the cost containment in the bill should have been bolder. And that's really why now, after having gone through the various provisions, the challenge I would have is, okay, how? Do you want more Medicare Advantage reductions? Do you want even stricter provider payment reductions? Do you want the pilots that are in there on accountable care organizations and bundle payments to have been larger? Do you want, Lord forbid, the Medicare Commission to be even more powerful? So what exactly is missing that one would want? Now, in all of those categories, I'd say things were, in many situations, things are there, but watered down a little bit. Let me give you an example. There is a penalty, as I mentioned, against high readmission rates for hospitals. One of the problems that we face in the current system is hospitals, 20% of Medicare beneficiaries are readmitted to a hospital within a month of being discharged. Most of us would not voluntarily want to get readmitted to a hospital unless it was absolutely necessary. There have been hospital systems in the United States that have succeeded in reducing readmission rates and then concluded that they couldn't afford to continue that because they weren't getting paid for the delayed readmission. And so stopped the practice of reducing readmission rates because it was killing their bottom line. That makes no sense. So the bill includes a penalty now against high readmission rates, but it's a pretty modest penalty, a couple percentage points. So perhaps that could have been larger. But I think when you drill down into, and I hope maybe during the question and answer period, we can discuss the specific things that are missing beyond medical malpractice and beyond perhaps dialing up a few of the provisions that should have been in a cost containment bill, because I don't think there are that many of them. Another issue that we already touched on is Congress will reverse some of the savings in the future. That may well be a risk, although as I discussed in the excise tax setting, I think it's less, it's not as guaranteed as many of the critics suggest, although it is a risk. The irony I find is that most of the people who are complaining about the lack of cost containment in the health bill are the most eager to then reverse the cost savings. So there is a little bit of cognitive dissonance actually, it's actually quite a remarkable feat, because without naming names, there are people who are saying the bill does nothing to contain costs, and then simultaneously saying we're going to repeal these provisions that reduce costs, but by the way, they don't. So that is a risk, but I think that really speaks to the fundamental challenge, which is that the issue is realizing that first curve that I showed you with the reductions that are built into the law and effectively implementing and sticking to them, not whether there are major things that are missing beyond medical malpractice from the legislation itself. It is mostly a question of execution and willpower on implementation, and the success that we have in building these institutions and the evolutionary approach that's necessary, and not there's some big missing piece that somehow none of us thought of. Although during the question and answer period, you'll have the opportunity to add your thoughts to that question. Then I'll close with the following observation. There's been a lot of discussion about the impact of the election on the health bill. This, I do think, is a very salient and real concern. I think it's less likely that there will be large pieces of the health bill that are repealed, and more likely that there will be a significant funding fight over administering the bill. In which case, we will wind up in the worst of all possible worlds, because the provisions of the bill will still be the law of the land, but will administer them incompetently, behind schedule, and create lots of confusion and unhappiness. The reason that I think this is a real risk is precisely that repeal of the major provisions is less likely, in my opinion, and that if you think about the political economy of the fight, it sort of leans towards the underfunding crowd. CBO has suggested that it will cost somewhere between $10 and $20 billion over the next decade for the IRS to monitor enforcement with this, for HHS working with the states to set up the health exchanges that will be a key part of the coverage component, and so on and so forth. So let's just take $1.5 billion a year as the central estimate. If the Congress provides $1 billion a year for that activity, which would be a significant gap between adequate funding to implement well and the level of appropriated funds, you'd be forcing the President of the United States to stand up and say, I know this bill that, by the way, is not particularly popular right now. They've given me $1 billion a year to implement it, but I really need $1.5 billion to implement it well. That doesn't strike me as a particularly winning argument in the current environment. And if layered on top of the leverage, most people see the split in the House and Senate as suggesting that the House won't necessarily get to do very much. The problem with that is that there are a few choke points that can be used to maximum leverage. I think the most salient one is the debt limit that will be hit early next year, and that will need to be raised in order to avoid a massive problem in Treasury securities, and for which you will need the House of Representatives to agree. So a situation in which the House has provided appropriated funding of $1 billion a year, and in which they say, we'll vote for a debt limit increase, and one of the three conditions is you don't go above that $1 billion, is a very difficult situation to be in. And the problem, of course, is the one that I mentioned, which is that the potential is then not particularly well realized because the administration is particularly challenging in that kind of environment. So let me just wrap up by saying no one should pretend this is perfect, and there will inevitably be adjustments made along the way. I would favor one immediately to get out in front of the repeal debate and propose the kind of tort reform that I've already suggested, just to be on a proactive stance rather than a defensive one. But on the other hand, I think the conventional wisdom with regard to this component, the cost component of the bill, has been significantly off relative to the reality. And in particular, I at least can't think of many other ideas that would be beneficial that are not part of the legislation. And the key thing over the next 5 or 10 years is building out that health information technology backbone, getting these institutions up and running, because this is going to be an evolution. It's going to be a process and not a one-off set of proposals. It will never, healthcare cost containment is not like studying for an exam and then you're done. It's like a diet that needs to be obeyed, unfortunately, over an extended period of time in order to be successful. So again, thank you very much for welcoming back to Princeton. It's delighted to be here. And I will take questions. What I would ask is that since we are at an academic institution, if we can defer to the students to lead off on questions, and then any non-student members of the audience ask thereafter, that would be great. But that requires the students in the audience to step forward so that your place is not taken by the non-student population. So the question was, why do this excise tax on insurance companies rather than just changing the tax exclusion, which is a more direct approach to a similar issue? And it's a good question. I think you've touched upon the answer, which is just one of viability. And as you may remember, the exclusion itself was a prominent part of the presidential election. And many people had taken positions that would have made it quite awkward to address the exclusion in a direct fashion. But from an economics perspective, this is very similar. So I guess the flip side is, what's the harm of doing it this way other than a little bit more, a little less direct impact, although it's actually quite similar as its effect increases over time. One of the things I should have mentioned is a key part of this excise tax is that it's indexed over time, the threshold, to a much lower growth rate than the projected healthcare cost growth, which will provide pressure to reduce cost growth over time. And over time, its effects are quite similar to other tax proposals that have previously been floated in other settings. Other questions? Right next. Yes, sir. Right. So the question was about the so-called sustainable growth rate formula, which applies to doctor payments under Medicare, and which, by the way, has a temporary patch which is expiring at the end of this month. So you'll probably be hearing a lot more about it as the month rolls forward. Let me answer this in a couple different ways. The first issue surrounding the sustainable growth rate formula, so you didn't directly ask this, but I'm going to answer it anyway, has to do with the charge that, look, a lot of the constraints that are built into the health bill are never going to happen. Look at what happened to the sustainable growth rate formula. Congress put in this cap on payment rates, and then it keeps waiving the rules. Clearly, the same thing will happen. And two observations are worthy of note there. First, my view of the sustainable growth rate formula is, even though there are these temporary patches that are continually applied, it still has applied downward pressure on physician reimbursement rates relative to what it would have happened in its absence, because the patches tend to be occurring at basically no change rather than the full increase that would have occurred in the absence of this whole system. But it's absolutely the case that there are all these patches provided, and the original path is not the one that is occurring in practice. And the key difference between that and at least the theory of the case behind the approach in the health bill is all that did was impose a cap. It didn't get at the underlying drivers of healthcare costs. So if all you did, the analogy would be to just put a cap on Medicare costs and say, well, that'll work, without trying to get at the underlying drivers. You need both. You need a constraint that sort of forces action, like the SGR, but then you also need to be getting at the underlying micro drivers of those overall costs. And that's what a lot of the other provisions in the health bill are at least aimed at doing. So I think there's a significant difference between an aggregate cap without any underlying support and one that's a component of an overall approach that tries to get at both the macro and micro end of things. You had then asked about its relationship to the Health Act and what have you. And one of the things that was popular on cable media was to say, oh, the CBO score of the health bill was misleading because it didn't include the necessary fix, the necessary patch to doctor payments. My own analytical perspective on this question was the right way to analyze a new piece of legislation is to evaluate what it does relative to what would otherwise occur. And the doctor patch was always going to happen. It was like the alternative minimum tax patch. We have these systems, these series of things that we've unfortunately fallen into. The Congress always steps in and patches. And that was going to happen regardless, both with regard to the AMT and the SGR, the doc fix, regardless of whether you had a health reform bill or not. So if you look at the marginal effect, the effect of the legislation relative to no legislation, the CBO score actually gets that right, for whatever it's worth, although there's been a lot of back and forth about that. That having been said, one of the missed opportunities in the bill was the SGR itself also needs to be addressed. The way that we reimburse doctors, both on a technical level and across specialties, I think is flawed, and everyone agrees that we need some change to the sustainable growth rate formula, and that was not tackled. So I think it's more of a missed opportunity than an accounting gimmick in terms of its absence in any significant way from the health reform bill. I hope that answered your question. How about right? I'll spread out in a second. How about right there? Oh, apparently you're supposed to walk. If you could come down to the microphone, that would be terrific. Don't trip. Well, then we'd be violating the student's first rule. There we go. Come quickly. Thank you. You don't have any shoes on. Okay. Sorry about that. Sorry. I think look, I will leave aside the sort of Machiavellian political perspective and just say, clearly there are different visions for how the health system should evolve. So if you look, and he's actually a friend of mine, if you look at the proposal that Paul Ryan of Wisconsin has put forward, that's a much different approach than what's in the health bill. And I think it's more conceptually consistent with the approach that many conservatives would like to adopt. You combine that with the observation, which is that many of their hot button items, I'll take tort reform, didn't wind up in any significant way in the final legislation. And then you combine sort of raw political considerations, which I will not, I don't feel qualified to comment on, and so won't. And I think you have the explanation for the adamant opposition. But I would also say, look, the one political comment I will make is I don't think it's just a communication issue, but I do think that the recent losses in the House were exacerbated by the failure to explain what actually was in the legislation. And the example that I've heard communicated to me that I think is particularly compelling, it's Keith Schuler, who, by the way, won re-election and voted against the bill, was asked repeatedly during his campaign about whether he'd vote for repeal. And he said no, even though, you know, from a very conservative district, that may have been a liability. And then he explained why. He said, do any of you really want your 25-year-old children who currently have health insurance to lose that because we repeal that part of the bill in the midst of a recession or in the midst of a weak labor market? I don't think so. And he'd go down the list, and all of a sudden the high-level opposition to Obamacare would weaken as you actually looked at the individual components. And I think there's been a failure to get down to that granular level, which is unfortunate because in many things, things that are popular at the 30,000 foot level are often unpopular at the detail level, deficit reduction and tax reform being good examples there. And things that are unpopular at the aggregate level, often more popular at the detail level. Individual members of Congress versus Congress itself being an example there. And by not getting down to more specificity, I think there were more losses than needed to be the case. But then again, that's not really anything that I feel academically qualified to speak to. Let's go over here.
So the new law does a lot to address issues of access and expanding access and coverage. And what we heard today talks a lot about controlling costs and also improving quality, which is sort of the next steps. But obviously there's a relationship between what we heard today and access. And I'm curious if there's any concern that kind of implementing these changes might have a negative effect and decrease access. We've already seen physicians are dropping a lot of patients on Medicaid, and maybe is there a concern that that will happen to Medicare patients and maybe patients with insurance plans that reimburse physicians or hospitals at lower rates?
It's always a concern, but it's not at the top of my list relative to the other issues in the health system. So I guess I would answer it that way. I mean, the experience in Massachusetts, which is often cited as being particularly salient here in terms of creating access problems, I think is much less clear than the popular descriptions suggest. And some of the surveys that have been cited as being quite flawed in terms of post and prior comparisons. So something to watch, but not at the top of my concern list. Hi. Clearly not everyone thinks they're win-win, but okay. Yeah, trust me on that one. I think the real question is viability. So Wyden and Bennett is something that I spent a lot of time examining as CBO director. One of the compelling characteristics of the Wyden and Bennett bill is that several of the co-sponsors said that they wouldn't vote for it, which that was my introduction to congressional politics. And the other point that I would note is that Since leaving office, I've spent a lot of time traveling around and talking to a lot of people. One of the things that may well turn out to be different than the projections initially suggested is there's a lot of discussion among corporate leaders about whether they should drop their plan and or put their employees in a exchange plan, even though there is a modest penalty of $2,000 roughly per employee in that kind of scenario. CBO suggested very little of that would happen. And that was partly because they assumed a fair amount of inertia in corporate decision making, and that was partly because it didn't really matter that much, because when someone moved from employment-based coverage into the exchange, the firm would pay the $2,000. You would have to pay the subsidy for coverage through the exchange, and so that would look like a net negative to the federal government. But you would also lose the tax exclusion on the employer-provided coverage, and it was basically, to a first approximation, on average, a wash. So it's also the case they didn't worry that much about the sensitivity analysis there, because at least for the federal deficit impact, it didn't matter that much. That may well turn out to be dramatically different in reality than what's projected. And there's actually a recent RAND study dialing down the inertia factor that has a lot more people moving from employment-based coverage into the exchange, which is to say you may come a bit closer to White and Bennett than you'd initially think, depending on that reaction. Last question. Yes, but it won't happen. And why would that not be? I mean, look, this is an example of, again, where the specifics get quite challenging. The fact of the matter is, and this is going to be unpopular to say in general, but at least over the next 5 or 10 years, a significant component of the deficit reduction that will have to happen over that period of time is going to have to come from the revenue side as opposed to the spending side of the budget. When you just go through the item by item viability on the spending side, there are reductions that are possible, but I've concluded that you're unlikely to get more than 0.5% of GDP on the spending side, and the gap that needs to be closed is at least 2% of GDP, which means the bulk will have to come on the revenue side. That having been said, it's always easy to talk about tax reform and revenue increases in the abstract, and then it gets harder as you get to the specifics. So as an example, people say, let's get rid of tax expenditures. Great. The leading ones are the health exclusion that we've already talked about, the mortgage interest deduction. And so you've even seen some discussion of, well, let's get rid of the mortgage interest deduction. There's a good example of it's challenging politically in any time, but especially coming out of a downturn that is very much related to the housing sector. The thought that we will get rid of the mortgage interest deduction over the next 2 or 3 years strikes me as not planetary. So to put the point gently. So the problem that I have is you often see this, let's do tax reform, and everyone agrees it would be desirable, but the political system is not capable of producing the detailed response, with very few exceptions, 1986 being one of them, very few exceptions, getting the detailed policy aligned with that overall objective. So I don't mean to be too pessimistic, especially at the in response to the very last question, but I am hoping that I'm being realistic. And again, I thank you all for having me here, and it's been a pleasure to come back.
We'll be holding a reception in Schultz Cafeteria in a few minutes, and if I could ask that you remain seated just for a couple of minutes so I can actually get the speaker into the reception, then I invite all of you to come and join us.